So good morning to our colleagues and friends. Welcome to our APOST Asia Pacific Laryngology Surgical Training Group. And then, so welcome to all the friends here. And hopefully our friends in Thailand and Myanmar are okay and safe after the earthquake that we noted yesterday. So this is our 10th NBI Laryngeal Imaging and Intervention course in Singapore at the Advanced Surgical Training Center in the Cadaveric Hospital. So brief introduction to APOST. We have been established since 2016 by our leading ENT surgeons to have a mission of promoting, training, education of otolaryngologic surgery, and then with practical values and contemporary principles and techniques in Asia Pacific. So we're just trying to promote training, education through our training programs so that we can provide comprehensive practical values, contemporary principles and techniques. And we'd like to work with the local and regional societies and associations to promote these education training purposes. So through lectures, dissection demos, supervised hands-on dissection, after the COVID era, of course, more online trainings, and now with e-learning platforms, hopefully that we can provide lots of training opportunities and practical tips for our trainees and our young specialists as well. Of course, our board members, we have so our chairman, we have Professor Michael Tong, vice chairman and treasurer, we have Professor Simon Cartney, our secretary general, Professor Jason Chan. Board members, we have Professor Richard Harvey, Professor Tsukimoto, Professor Narayan Yanan, Dr. Learn, and Dr. Spock. So we have a new virtual training on our iPad App Store only yet at this moment. We haven't developed through the Android platform. We have an app that can train the endoscopy by the nasal routes to the larynx as well. So if you have time, you can use this QR code and then download the app so that you can have some experience with this virtual training. And then through the media, we have Facebook. We have a website that we can log in with your IDs, and then we have all those training videos and the programs through this website. And then we can always contact our APOST secretary for further information. Today we have Professor Raymond Chung here sitting behind us here. So you should all know him. And Dr. Suda here at the front row. And me from Hong Kong, Dr. John Lee, to provide these lectures and the workshop as well. So as you can see that we'll start off with Dr. Suda with this her office-based laryngeal procedure. Then we'll have a pre-recorded lecture because Professor Shikimoto is busy in his country to do some emergency surgeries, talking about NBI in Laryngology, APOST. Then Dr. Ruben we'll talk about the essential developing of the practice that utilizes NBI. And Dr. Rakesh will be in our webinar in India to talk about preoperative and intraoperative NBI and laryngeal cancer during transoral laser surgery. And then me, I'll talk about the laser in laryngology. And we'll have a Q&A session, a nice break, and we'll jump on to the workshop. And we will talk about that after this. So a brief introduction for Dr. Raymond Chung, who all know now is a senior consultant in our department in National University of Hospital. He's also a professor in Yong Lu Lin School of Medicine at National University of Singapore. Dr. Priscilla, professor in ENT surgery at Chulalongkorn University as well. Dr. Shalini, if I haven't pronounced correctly, right? She's a senior consultant in ear surgery in Singapore General Hospital, Chief Medical Officer in Home Team, Ministry of Home Affairs. Me, I'm from Hong Kong, associate consultant in the Prince of Wales and Seoul National Hospital. With Professor Sukimoto in Japan, APOST board member, as you can see. He's a director in Department of ENT in Tokyo Metropolitan Cancer and Infectious Disease Center in Gome Hospital in Japan, and also clinical professor in the Department of Head and Neck Surgery in Tokyo Medical University. And Dr. Rakesh, consultant laryngologist and director in ENT Department, Health City Vistar Hospital in Lucknow, India. Also founder in Prospect AI Health Tech India Private Limited in Lucknow, India as well. And then also it is Rich ENT Center Voice and Airway in India. We want to thank our sponsor Olympus to support our workshop in APOST as well, and then particularly also ARC Laser Company to support our Laryngology workshop and also future advanced course as well. Thank you for APOST and ARC colleagues. So let's start with the first lecture. Dr. Tsuga, welcome. And,
thank you, John, and thank you, everyone, to invite me again as speaker and on the workshop. Okay, so I'm gonna start with something like in the morning, okay, with an office-based laryngeal procedure. Okay, so this is my disclosure. This procedure is independent and not influenced by commercial interest. So let's talk about history first. So the evolution of the office-based laryngology, why we do it today. So since the introduction of the topical anesthesia, cocaine, propane, and lidocaine, which is in 1943. So that's why it made the procedure more tolerable to the patient. And we thought the flexible fiber optic national also in 1975 that made a lot of a leap in the laryngology. But when you use it, you know that it happens that could decline and the picture is not quite good. So in the early 2000s, we have this leadership technology and that has more high quality image and also that can combine with the visual enhancement like color filtering and wavelength specific light that make the more convenient to do the procedure in the office. So what kind of procedure that we do in the office space? So we have this like pharmaceutical injection. You know, that's a lot of patients with this spasmodic dysphonia, tremor, maybe bilateral vocal cord paralysis that we can inject botulinum toxin through in the office. We keep more convenient for the patient. They just like in and out. Okay, and we also now using that for augmentation, laryngoplasty by injecting temporary injection like hyaluronic acid. Okay, you can inject that calcium hydroxide apatite to augment the vocal cord in unilateral vocal paralysis, and also that steroid. Okay, like in the airway stenosis or even the nodules of polyps that we treat them the patient in the office for now. Well, but more advanced treatment is laser, which John will give a kid insight about this later. So we can use a fiber guide laser inserted in the working part of the flexible scope. You can choose like there's a multiple laser that you can choose KTP, outside laser, diode laser, even carbon dioxide with a waveguide, and also the blue laser. Okay, which if you attend the panel with partner, you get a handle on that. Okay. And well, we usually do a tissue biopsy through the working channel too. Okay, that's well because it's more convenient to more than getting the patient to the operating room, general anesthesia, which some patients might not tolerate that. Okay, so this is give more accurate diagnosis for the cancer patient. Also remove the foreign body through that channel. So when you're setting up the office treatment, so you're gonna have to have some instrumentation and space. Okay, so you need an adequate space to accommodate the equipment, staff, and the patient, and also the nearby sterile area, just to cleaning your equipment. Okay, get everything done, and then rotating the patient. Okay, and definitely you're gonna need the better flexible scope, which is well now we do need a digital chip to get that clearer image to do the procedure. Okay, maybe you can have it with or without the working channel. Okay, video monitoring and recording system is very important because most of the patients maybe well, you have to record them before and after the treatment to get the idea what happened, to see if the treatment works or not. And also the other instrument, the biopsy product, injection equipment, data system, if you can use that, and a suction system. Okay. And sometimes with the topical anesthesia, some might prefer the nebulizer, just to nebulize in the airway. So you're gonna need that nebulizer system in the office, and also that the Abraham cannula is like a curve cannula that you can drop in the lungs. So it's very convenient. Well, if you can get a hand on that, it's pretty good. Okay, or you can drop the lidocaine through the working channel too. And you're gonna need to have the proper ventilation for this. Okay, after the COVID, we have to rearrange everything. So because that's all right for the infectious control. The patient shall need to be comfortable, have some head support, okay, then reclinable, just in case that we have to reposition the patient, or maybe they get some hypovolemic problem, okay, pain, okay, so this is more convenient. And also emergency card, in case that we have complication working from the topical anesthesia. So that's a common question. Do I need a stroboscopy for doing the office-based procedure? Well, you may need it if you treat it like more a professional white user, because this will permit you to have the better accuracy in the diagnosis, especially like the scar, or maybe you have to treat the finger, which the fundamental frequency will be normal, but they're gonna have a problem on the specific range of that piece. So you might need that if you have that kind of patient in the clinic. And the cerebral microscopy permits the examination of copper body function. Okay, so it can identify the specific pathology like asymmetry in oscillation, okay, a dynamic segment like in the scar, okay, and blood submucosal, or this is the mucosal pathology, and also specific brain vibration in the different pitch. So let me show you the stroke one. I was going to just a quick one. Okay. So this is a 90 rock lens. Okay. You can see that the picture is better. It's quite good. Okay. Image quality. You can see this is the data sheet. Right.
Okay, we can log in.
Get that specific like this that what it is that will be better to draw or maybe like tiny papilloma or we could take care we want to see if it's a cancer or not. Okay. So let's start with the patient preparation because the patient will be the key. You have to be cooperative to this. So the description of the poster in detail would be helpful for them, so they know what's gonna happen to them. Okay, and also after the procedure, because I usually ask them that okay, I have anyone with you in case that they need to transport back. Okay, and you need to tell them what the symptoms after the procedure, so they will get follow us, they cannot eat or at house, things like that. Okay, and then they need to cooperate to every step of the procedure. Okay, and with the some anxiety and management, okay, usually I don't have to get any cue for them, but sometimes with a very, I would say, jumpy patient, I might ask them to get some right hand anti-anxiolytic agent before doing this. Okay, but I have to tell them that do it down the procedure. Okay, the monitoring system is optional. Okay, because most of the patient when you select to do it, you're gonna select that the patient that big enough. Okay, do not have any anticoagulant therapy. Okay, but well, in the very old or maybe like some patient who need to be monitored, then you might need that pulse oximeter and then some blood pressure just to see if they have any complication after that. Okay, and they have to sit in the upright positions. So let's start with the topical analgesia. Okay. Well, you're gonna need that nasal congestion, okay, because you are using the flexible endoscopy. You might spray it in the nose or get it in the corner places and then tap it in the nose for a few minutes and then breathe. Okay. To suppress the gas reduction, okay, well, you can have that 10% little spray the base of tongue, and to the peel of the pillar of the thoracic or posterior pharynx, or you can add 2% lidocaine drop to the original or that Abraham cannula, and but some might use that 4% lidocaine aerosol nebulizer just to numb in all that. I found it very helpful if you want to do like the procedure on the hypopharynx too. Okay, because it gives that more like overall numbness in the hypopharynx. And well, to reduce that cough reflex, okay, you might need to do that intraluminal lidocaine injection through the neck. I usually inject it through the hypothyroid membrane. Just spray it in the less than 1 cc and ask the patient to gentle cough, just a bit like this, okay, just to make this like burst out, okay, and then get to the other area in that throat. And for sometimes we do that tranasal esophageal. So you're gonna need to have that to numb in the hypopharynx by 2% lidocaine viscous solution. So you ask them to start on that and then swallow. So this is how I do the intraluminal topical injection. So that's a skin injection first, okay, only on the skin, like a small amount, and then get through the hypothalamic membrane and then inject it intraluminal. Well, I usually do not inject it in the hypothalamic membrane because it makes like the membrane to be infected, and then when you inject like botulinum toxin, you will get that area thickened, and it's very difficult to navigate your needle. So when you use you can see that you use a lot of lidocaine in this procedure. So you have to be careful about that lidocaine toxicity, because that local injection toxicity, the last, okay. So there's only some neurological side that you have to do for it. Okay, for the oral numbness, feel the metallic taste in the tongue. Okay, dizzy, tinnitus, and seizure. This is a major complication for that. And they might have the cardiovascular effect too, hypotension, bradycardia, arrhythmia, cardiac arrest. Okay, and for severe complications could be like coma, okay, collapse. So people need an emergency card in the clinic. Well, when you spray the area, there could have some toxicity too. So, well, for local, they might have some fluoridation, which is pretty common. Just you have to tell them before, prior to the spray, okay? And they might have that aspiration rate because they reduce the gas reflex. Okay? And could have some seizure too if you spray it too much. Okay, and there's also the maximal globinemia effect. If you have that, okay, the patient will get like dyspnea, cyanosis. Okay. So the key is to prevent it to happen. Okay, so you can calculate the dose. Okay, maximum dose is 4.5 milligrams per kilo without epinephrine, and 7 milligrams per kilo with epinephrine. Okay, and you have to early monitoring for the sign of the effect. Like numbness, tinnitus, what is it? And if that airway or oxygen support in case that they have the problem, prevent aspiration and ensure that they have adequate ventilation. So treatment for severe local toxicity is like rhythmic emulsion therapy, intravenous. Okay, and for methylmoglobinemia is methylglue. So let's step up to the laryngeal injection technique. Okay, so you have this option to inject anything in the larynx. Okay, you can use a transoral needle. It's going to look like an abracanula with that needle, and it's a needle. Okay, it's curved. It go through the mouth. Okay, you might have that flexible scope for visualization and then get that through the mouth. Okay, this is you have to select a patient for this because it's gonna induce a lot of gas reflex. Okay, and you can use that sclerotherapy needle. Okay, it's a long needle through the working channel of your laryngoscope. I usually borrow the GI from my colleagues' GI. Sometimes I use it, but I find that because it's very long, when you inject something that long, you're gonna need to get it like more doses. Okay, this is like a waste of money. So I don't usually do that. Okay, except I want to do that with the hypopharyngeal injection with a really long needle. So we got that 100 units. So you can have that with you don't have that amount of Botox in. Okay, and but the most popular approach is the percutaneous approach. So you do it through the neck with the visualization with the flexible scope. Okay, so you can do that through the hypothyroid approach. Okay, we have the different technique midline of touch in transthyreal cartilage for younger patients, so you can poke right into the cartilage or through the transthyreal ointment. Mandy, you might need to remind me if I run out of time. Thank you. Okay, so to do a hypothyroid approach, so this is like you go through the midline of the hypothyroid membrane. Okay, it's pretty easy, and it is the first approach I will select. Okay, unless I cannot do it, I will change to other approach. Okay, you can get that strength or single bell needle, 30 to 40 degrees. I usually use the 25 gauge needle, 1.5 inch. Okay, that's enough. Okay, except for the very big male patient, you might get that a longer needle. This is very difficult to find. Okay. So this is the video showing an injection of the vocal the dexamethasone in the vocal nodules. With no sound. Okay. So this is go through the midline. You can see the needle in the midline, and then it's like just now get to the left and the right. Okay, it's just like poking, not too far. If you go too far, you get like far back to the arytenoid. You do not want that. And there's another technique for hypothyroid approach. They call it touch, which is then by we describe that in the regulation. Okay, so you go like not midline, but like just lateral to the midline. Okay, at the junction of the thyroid and hypothyroid membrane, which will avoid you to entering through the airway. Okay, and then you kind of like just walk through the hypothyroid membrane and then get the needle like angle up about it more than 45 degrees to the lateral. So this is the video showing the technique. Okay, this is the hyaluronic acid injection for right vocal cord paralysis. This patient, you can see that when the needle get in the parabolic state, you just jiggle it a bit to see where the needle is. Okay, sometimes I can poke through it. Well, but you need to have enough topical analysis for this child, the patient might cough. Okay, without entering the airway, they're gonna reduce their cough effect. They're not triggering the cough effect. So I will poke just a little and then retract it until I see that okay, get in that area, like in the mid vocal for this is for hyaluronic acid injection, and then inject. Okay. So you can see the vocal cord is now. Okay. Okay. This is more convenient to do in the office because after that, you can ask the patient to voice to talk, and you can see that it's good or not. If it's not enough, okay, inject more. This is pretty good. So I usually overcorrect it just a bit, okay? But I find that if you go too much, inject too much, the patient will not be that way. They will not like that. So don't try to overcorrect that much. It's pretty easy doing in the office. So is it like immediate after that, I ask the technique. You see that the gap is better. I have a video now. Okay.
กรดไหลย้อนที่คอและกล่องเสียง
ทำให้เกิดการระคายเคืองต่อทางเดินหายใจส่วนบน เช่น
หลอดลมกล่องเสียง
we
โพรง
inject
จ
the
มูก หรือทำที
patient from the
มีแน่
when you see that you have that gap.
ที่
This is
เกิด
the
จากกรดในกระ
after
เพาะอาหาร
2 months
ไหลย้อ
after
น
the
ขึ้นมา
injection.
ผ่าน หูรูดกระ
And
เพาะ
so
อา
when
หาร
do not
ส่วน
have
บน
that
อย่าง
NBI
ผิดปกติทำให้เกิดการระคายเคืองต่อทางเดินหายใจส่วนบน เช่น หลอดลมกล่องเสียง
we have long focus pockets.
ๆน้ำมูกค่ะสองทีสวยทีค่ะคราวนี้อีเบา
It's the
ๆขอให้ตับที่หนูค่ะโอเค
inside headache to be. So you happy about
เต้
that?
นสูงไหวไหมคะสูง
ทำให้เกิดการ
So we move to the next approach, hyper-ion approach. So for the patient, well, with more difficult to see, okay. Okay. So and when you want to see when you need to pee, okay, this is pretty have more advantage because you can access all the area of the larynx, the glottic, the supraglottic, the glottic, okay. Well, when you want to inject some steroid for like granuloma, which is far on the back, okay, you cannot go through that hypothyroid approach. It will be more difficult. So the thyroid approach is more convenient to do that. So, but because of the thyroid node, you need to double bend the needle, like 45 and then 45 degree. Okay, to when you get it in there, it's gonna be right over the vocal fold. Okay, when you go to the neck, gonna be just above the thyroid node. Okay, and then you just like push the needle all the way down. So when the venom nerve enter to the airway, it's gonna be curved over the vocal fold. You can see that, okay, it's gonna hold just above the anterior commissure, and then you just like turn your hand to the right or to the left, like clockwise or anti-clockwise, so the needle will turn. You see me injecting botulinum toxin at the vocal fold. Well, because injecting the Botox now in the TA muscle right away, you get that radio noise longer, and the patient doesn't like that. So now, in the upcoming study, they found that injecting in the vocal fold give the same result, okay, but less radio noise. But you're gonna need more botulinum toxin for this. Okay, so the patient is, if they are a professional wine user, they don't want any bleeding after the injection. So now I will inject them in the vocal fold. So this is another case, injecting the hyaluronic acid with the trial approach. Okay, but this patient is male. Okay, so I didn't bend the needle. Okay, when doing that, without bending the needle, you need to go like the needle will be like on the vertical position. It'll be like vertical to the parallel to the neck. Okay, to the bend it, like bend it, just position it like parallel to the neck to enter to that area. So if he had a vocal paralysis after the spine surgery, was very hot, and he had some liquid aspiration to inject this. to the 25 gauge needle. Okay. And well, for steroid injection, you can select that for an average stenosis scar, nodules, polyps. So this is this gentleman is he has subglottic stenosis, but there's a lot of underlying conditions, diabetes, heart disease, and he has great bone, but he needs his body to talk. So I inject the diazepam through the hypothyroid approach in the subglottic. Well, you cannot see the needle because it's underneath the mucosa, but you see the blanching that happens after you inject in that is here. And that's several studies right now that show the result that with the multiple steroid injection in the subglottic cells, well, finally you can let them, but you have to select the patient for this. And they have to be cooperative and the subglottic cells usually is not more than grade 3. And well, I'm going to go quick through this because John will have to talk about this. You can use the laser in the office to do the very small lesion like a small papilloma patient. Okay, we could pay here. Okay, this is diode on the left. This is a vocal leukoplakia on the right. Okay, using a blue laser just to cauterize that and have that biopsy through the working channel. The drawback of doing a tissue biopsy through the flexible endoscopy is you might not get enough tissue. You get too superficial, too small, okay, and they might miss that cancer diagnosis. That's a review about this, okay, about the doing this in the office, and I think the sensitivity is not more than 70%, okay, but the specificity is high, like 97%. So when doing this, usually I do the multiple biopsy, like many times to get enough tissue for the pathology. So we also do the unsedated transnasal esophagoscopy in our center too. So I had a study in 2015 with my colleagues. We review the patient who received this to evaluate the indication, outcomes, and complication of that TNE. And the result is to have 58 patients who underwent this, and the mean age is like 50 years old. And you have that, usually we do it more like for secondary primary cancer surveillance in the head and neck cancer patient. Okay, the incidence is around 9% for our center. In the regulator, it's around like 5 to 10%. We might got that esophageal cancer in the head and neck patient. So it's very convenient to get a patient in doing the deep transnasal and then they out in the same morning, okay, just to survive when they cancer, and also the swelling problem, staging of the head and neck cancer, and the voice problem. And we have 3% that is two patients have that major complication, waggle, syncope, and major tissue bleeding. We have to bring the patient to the OR to stop that in the esophagus. So, let me quick about this. So doing this, okay, we'll need a small caliber. You can get a small caliber GI scope less than 5 milliliters go to the nose. Okay, and obviously you have to numb the patient. I use the spray and certain whisker. Just ask them to gargle and then swallow. And you can see that it's different from the end of gastro because the patient is still breathing. There's a lot of movement during that time. But this is for surveillance, so you have to get. I will get like antigrade until I reach the stomach, and then I'm gonna recuperate the scope, and then very slowly and take a look around to see if there are any lesion that I need to biopsy. The only area that you might not see during this is the post-cricoid, because when the scope get in, okay, they don't swallow like and swallow the NG, like an NG, nasoplastic tube insertion, but it's very quick, so you're gonna miss that post-cricoid area. So this is not good for the post-cricoid surveillance. Okay, but you might ask them to do the bowel thermal just to get to see that area too. So for post-procedure care, I will always ask the patient not to drink or eat like for about half an hour. After that, because of topical anesthesia, that will be the risk of their aspiration, the completing precaution if they do use some injection or tissue biopsy. Maybe can give them some analgesic, but I find that it's very rarely I have to give them some painkiller because they will fly. Anti-reflux medication if you do some laser treatment, okay, and adequate hydration. One rest is about 1 to 3 days if for injection, and for longer about a week for laser treatment. That's a combination that there's a review of the study. Okay, for biopsy, you might got the aspiration, vasovagal reaction, epistaxis from the nose. Okay, and breathe at the lesion. For vocal cord injection, you might get that with the steroid, you might get that by application. Okay, edema, even the respiratory obstruction. If you do the simple fire for vocal cord injection, if you inject too much in both of the vocal cord, you might get that, or it happened in the abductor spinal dysphonia. If you inject at the PCA too much, okay, it might diffuse to the other side. You might get that, at least temporary. Okay, hematoma. Okay, well, or X-ray voice improvement and granuloma after this. For laser, you might got a scar from laser. If you laser too much. Okay, and for the top dye laser, you might get that blood vessel rupture. Okay, this will not, it's a nightmare for the singer. If you rupture that blood vessel, they're gonna break that one for a longer time. So for take-home message, so the optimal surgical procedure said efficient, okay, and reduce the need for general anesthesia, okay, and well, you're gonna require a disposition endoscopy with working channel if you can, just to enhance the visualization and procedure precision. Okay, it's a minimal invasive technique, and well, you can combine the laser treatment, okay, biopsy, or diagnosis and better like therapeutic outcome. And well, the key point you need to select the proper patient for this. It's very crucial that they cooperate during the procedure. Okay, and with communication are very rare, but you need to recognize that and manage that earlier. For future research, okay, well, maybe we need to refine the technique. So, like one purpose of now today, if you look at the study, there's a lot of technique for this. Okay, maybe in the future they have a comparable study about this, and then more enhanced technology with Dr. Taro, Raymond, and Dr. Rakis to talk about this in the later topics. And so this will be better if we can validate the oncologic outcomes with this fitness. Okay. So, yes, that's my point.
Good morning, ladies and gentlemen. This is Taro Sugimoto from Tokyo, Japan. Today I would like to talk about NBI, narrowband imaging, in laryngology, especially about NBI topic in hypopharynx and oropharynx. These are today's overview. First, I'd like to talk about trends in pharyngeal and laryngeal cancers in Japan. Previously, head and neck cancers are diagnosed as advanced stage at initial consultation, also in Japan. However, they are becoming to be found in earlier stages recently due to the advancement of endoscopes such as NBI and the improvement of diagnostic techniques of endoscopists and ENT doctors. So I would like to show you the trends in pharyngeal and laryngeal cancers in Japan from the report of Head and Neck Cancer Registry of Japan. First, laryngeal cancer. In laryngeal cancer, there has been little change in the frequency of detection of early stage cancers such as TIS and T1. The same is observed for the rate of N0 cases. Next, oropharyngeal cancer. The rate of early detection of oropharyngeal cancers appears to be gradually increasing. However, in contrast to the increase in the rate of early detection of primary cancers, the rate of N0 cases detected in the oropharyngeal cancer hasn't increased at all. This is thought to result from the increase in HPV-related cancers, which tends to metastasize to cervical lymph nodes even if the primary tumor is small. Lastly, hypopharyngeal cancer. As for hypopharyngeal cancer, the rate of TIS plus T1 cases is increasing every year, reaching 26.5% in 2019. And the same is observed for the rate of N0 cases. Along with these trends, the rate of transoral resection for hypopharyngeal cancer is also on the rise. In 2019, in 26.5% of cases. These results suggest that endoscopic examination combined with NBI contributes to early detection of cancer and function-preserving surgery, especially in hypopharyngeal cancer. Next, I would like to talk about history of early detection of oral and hypopharyngeal cancer using NBI. In 2002, Muto et al. Reported that superficial cancers in the oral and hypopharynx can be more clearly visualized by GI endoscopy using NBI and magnifying endoscopic function at the Japanese Academic Conference. This was the first demonstration in the world of an easy method for early detection of superficial cancer of the oral and hypopharynx, which had been thought to be almost impossible to detect. In 2004, Muto et al. Published the paper showing that early stage cancers of the oral and hypopharynx could be clearly detected easily, which had been difficult to find. Watanabe et al. Reported that even an ENT endoscope with an NBI, a narrow caliber, can be used for early detection of pharyngolaryngeal cancer using NBI. Microvascular structure of the normal esophageal mucosa is shown in this figure. These structures exist from deeper to shallower as follows. Submucosal veins in the submucosal layer, arborescent vascular networks in its shallower layer, and oblique vessels in its even shallower layer, and lastly, intraepithelial papillary capillary loop. We call this IPCL on the tip of them. NBI can visualize these structures. This is a upper GI endoscopic view of the normal pharyngeal mucosa. We can see normal brown shallow vessels and green deep vessels. This is not the magnifying endoscope finding. And NBI make it possible to visualize not only these structures but also changes of these structures in the cancer lesion as brown dots. NBI can identify the extent of early stage cancer by visualizing IPCL changes like dilatation as clusters of small brown dots. In these cases, the arborescent vascular network has disappeared and the IPCL changes are visualized as brown dots, showing the extent of early stage hypopharyngeal cancer as a brownish area. Next, I would like to talk about NBI-based diagnosis and how NBI can be used to detect early stage pharyngeal and laryngeal cancers. What should we pay attention to for early cancer detection? Please pay attention to reddish area, puffy appearance, leukoplakia, melanosis, using distant normal light observation. Observe the above abnormal area, including surrounding area, closely, and please pay attention to detect the arborescent vascular network disappearance in the mucous membrane. Then use NBI function. Finally, you can identify the early stage cancer near the above abnormal area as brown dots. And please observe from as vertical direction as possible, especially in case of posterior wall pharyngeal wall cancer, not from tangential. So I recommend transoral observation for this kind of cancers. And NBI function is useful to detect small lesion, like including millimeter cancer, and to detect superficial lesion, for example, carcinoma in situ, and to differentiate carcinoma from inflammation in case the lesion is reddish by the normal white light. And lastly, to identify the extent of the cancer spread in detail. So I would like to show you some cases. This is an example of hyperpharyngeal cancer of right piriform sinus. In this case, you can see leukoplakia, reddish area, arborescent vascular network disappearance. And you can find the cancer as brown dots. This is also the right piriform sinus cancer. We can see puffy appearance, arborescent vascular network disappearance. In this case, we can identify the extent of the cancer spread in detail. We can see the borderline of cancer and normal tissue, normal membrane. And this is recurrent cancer case, RT1, in the right piriform sinus. White light image only demonstrates the small and thin protruding whitish lesion in the right piriform sinus. However, NBI image demonstrates branched and slightly dilated vessels on the surface of the tumor after the endoscope is brought close to the lesion. This finding suggests that the cancer invades into the subepithelial layer. Next, oropharyngeal cancers. This is P16 negative oropharyngeal cancer case. In this case, we can see melanosis. Cancer often occurs in the vicinity of melanosis, and arborescent vascular network disappears in cancer lesion. And I will show you two cases of P16 positive oropharyngeal cancer. Of first, right tonsil cancer. Anyway, could identify atypical vessels on the surface of the cancer as brown dots easily in this case. Next case is also P16 positive oropharyngeal cancer. This case is earlier stage case than case 1. In this case, CT could identify the cancer, but NBI couldn't identify atypical vessels on the surface of the cancer at all. This is a pathological findings of this cancer. This is because HPV-associated cancers originated from the reticulated epithelium of tonsil crypts, and in case the primary tumor is in an early stage, the mucosa on the surface of the palatine tonsils is normal and the cancer is beneath it. Therefore, early stage P16 positive oropharyngeal cancer cannot be identified by NBI. In this kind of case, NBI is ineffective. Next, I would like to show you the natural cause of early-stage pharyngeal cancers. So, when should we perform surgery for very early-stage pharyngolaryngal cancers like CIS, carcinoma in situ, or dysplasia? NBI can detect pharyngeal and laryngeal carcinoma at the stage of dysplasia or interepithelial carcinoma. To answer this question, we need to know the natural cause of early-stage pharyngolaryngal cancer. However, the details of the natural cause early-stage cancer isn't yet known. So I would like to show you some examples of the natural cause of early-stage pharyngeal cancers. First is hypopharyngeal cancer case. Initially, the cancer was intraepithelial. However, when he came to the hospital 3 years later, in this case, the intraepithelial cancer became an invasive one 3 years later. His general condition prohibited surgery, and he underwent radiation therapy alone. Next case is also hypopharyngeal cancer of right posterior wall. These are apogea endoscope findings. These are ENT endoscope findings. At the time of detection by apogea endoscope, no obvious dot-like abnormal vessels were found in the lesion by ENT endoscope. However, 1 year later, ENT endoscopy also showed obvious changes in the lesion, so we could identify the abnormal vessels and enlargement of the lesion. So the transoral resection was performed 1 year after detection by apogea endoscope. Next case is the double cancer of oropharyngeal cancer of superior wall and hypopharyngeal cancer of right piriform sinus. These are ENT endoscope findings by white light, using white light. We could see the melanosis of the top of the uvula after 2 years and 5 months later, after first detection of the lesion. These are ENT endoscope using NBI. These are apogea endoscope. So the transoral resection was performed 5 years after first detection of the lesion. These ENT endoscope findings using white light and NBI. And these apogea endoscope findings using magnified function. Apogea NBI endoscopy show that microvascular changes on the cancer surface were dot-like at 1 year and 3 months after first detection of the lesion, but it changed to elonged vessels at 4 years and 4 months after, suggesting that the depth as well as the extent of cancer increased. The transoral resection was performed 5 years after detection. Last case is hypopharyngeal cancer of left posterior wall. The lesion was found by upper GI endoscope during a detailed examination of another lesion located in the deep posterior wall of the hypopharynx and was difficult to identify by ENT endoscope. It had changed from dysplasia to obvious intraepithelial cancer in 1 year and 5 months and was resected transorally. Gold staining prior to resection showed that the lesion was stained pink. We call this pink color sign, suggesting that this was cancer, not dysplasia. Lastly, I would like to show you the slides about evaluation of cancer depth with intraoperative magnified NBI endoscopy of upper GI endoscope. This is a paper from the prediction of depth of invasion in superficial pharyngeal cancer. The depth of the cancer correlated with the image of microvascular architecture of the surface on the surface of the cancer by magnified endoscopic observation with NBI. The thickness of cancer increases from B1 to B2 to B3. The same correlation was observed in cases with prior treatment, such as induction chemotherapy. So, in cases in which only B1 vessels are seen, there is no muscle layer invasion, so the muscle layer and fascia can be preserved during resection. In cases with B3 vessels, the cancer is deeply invasive and there is a highly possibility of muscle layer invasion, and the muscular layer should also be resected. So I would like to show you 2 cases. First case was a case of shallower cancer with only B1 vessels, observed on intraoperative upper GI endoscopy with magnified NBI. We cannot use this function by ENT endoscope. In this case, only B1 vessels was seen, so the lesion was considered not to invade the muscle layer. The cancer lesion was resected with preservation of the muscle layer and fascia. Next case was a case of deep cancer with B3 vessels of cancer of the posterior wall of hypopharynx. In this case, B3 vessels prolonged and thick vein were seen, so the cancer was considered to be deeply invasive, and there was a high possibility of muscle layer invasion. We could identify the cancer using MRI. The cancer was resected with a partial muscle layer attached. In this case, the entire muscle layer of the posterior wall of the pharynx was partially resected. This is a pathology of excised specimen. Muscle evasion existed. After 3 weeks, wound healing in the resection layer progressed, and oral feedings were initiated. So I'd like to conclude that by using video endoscope with NBI function, we can identify early pharyngeal and laryngeal cancer, including recurrent cancer, easily, except early P16 positive oropharyngeal cancer. Some knowledge is required to utilize this function effectively. The natural history of very early stage pharyngeal carcinoma cancer, such as dysplasia and intraepithelial cancer, isn't yet known. But in my experience, the lesion increases and worsens within 1 to 2 years, and routine endoscopic observation and surgery within 1 to 2 years after first detection are recommended. Intraoperative magnified NBI function can be used to predict the depth of cancer and arrange the depth of resection. Thank you for your attention.
We'll invite Dr. Raymond Chung for the next topic, the essential of developing a practice that utilizes NBI lecture.
Good morning, everyone. Welcome to Singapore. I'm Dr. Raymond Chung. I'm the associate professor here, also the head of the head and neck tumor group. Today, I'm going to give a talk on what Dr. Sugimoto has mentioned before. It seems like, yeah, so NBI is everywhere, but actually, you need a bit of a preparation before you can utilize it nicely in your practice. So narrowband imaging, what's narrowband imaging? Narrowband imaging is not some magic, it's not some drug, not some X-ray. It's basically just an optical filter. Okay, it's an optical enhancement. Once you understand it's an optical enhancement, you have limitation from optics. So it basically accentuates two peak absorption of hemoglobin, 450 and 540, the blue and the green. So it will suppress the signals from other lights and accentuate. So sorry, my fault. Okay, see, okay. So I like this photo. So basically, this is the same. So for those who are photographers, this is on the left is a white light photography, which is looking around from a plane. You can't see much. But you switch it to infrared, then you can see the river because of the difference in the infrared signal. So NBI is very much the same, except it's not using infrared or ultraviolet, but a certain wavelength, the blue and the green, which the hemoglobin absorbs most. So why hemoglobin? Because we want to look at this thing, angiogenesis. So we all know about cancer cells, especially squamous cell cancer, which is so well researched in Japan, develop different patterns of capillaries between the normal inflammation and cancerous mucosa. With our white light and eyes, we all see red from inflammation and cancer. But when you magnify them and see it with an NBI, you can see the difference in the pattern. And recognizing this pattern makes you know what's a normal mucosa or inflamed mucosa versus a precancerous mucosa. Okay. The important thing is they want to pick up precancerous mucosa because that's the best use. If we see a gross tumor, we know it's a tumor. We don't need NBI. Is we want to see the precancerous lesion or in a cancer, adjacent precancerous lesion. So when we do our resection, we're not going to get a positive margin. Okay, so these are all the factors. If you look about like Avastin, they all add on these new angiogenesis factors. So erythroplakia is basically these new angiogenesis. in a gross anatomy term, and we look at it, the mouth, we have to see this redness. So what we need for NBI, we need endoscopy, we need a good light source, and we need a video processing unit and a monitor that can actually do this processing. So the processing and the light source are the key to get your NBI ready. So I'm going to talk about a little bit of the older system and the newer system. In more specific Olympus, because I'm more used to the system. They have actually two systems in terms of endoscopy. But now I think the products are moving on and they're emerging. So one system is a white light system, which the light source is white. So, and the other one, if you go to an endoscopy suite where they do the upper GI endoscopy and colonoscopy, they have this RGB system. The light is actually flashing a red, green, and blue light and combined together. So you can see a flash. If you can see there, they flicker, the light flickers. Because it actually rapidly flickers between the three lights, and the image processing creates a color image. So this is a white light system, where the xenon lamp, which is most of our ENT system is using in an endoscopy suite or in our clinic or in our operating room. So there are the RGB filters that filters it, the white light, and filters it and create. But the CCD, the color, the camera is actually a black and white. So it basically just use this to oh, sorry, I do it again. I mix up. I go back. So this is the RGB system. This is a system doing an endoscopy suite where they have the light and they use the filter to get the different colors. And then there's different colors. And then the CCD is a black and white CCD. So if there's a red light, it signals a red, a green is a green, and blue is blue, and then it merges together to make a color photo. Why do we like this? Because black and white CCD has a better, if you know about digital photography, has a better dynamic range and better resolution of a lower contrast. But then it flickers. So the color, when you look at the light, you see the flicker between the three colors. When they do NBI, they switch it only to use two filters, the blue one and the green one, and they don't use the red, and you get this composite color out, which is the NBI that you see. The benefit of this is because it's a black and white CCD, it gets a much better resolution. So if I'm going to use most of the time in doing NBI, I prefer this RGB system than the white light system that we use in ENT. So because of the better resolution of the CCD. So white light system, this is the one that we use for normal ENT scopes. Instead of using, they use the color CCD and use the filter to filter these two lights. And the filter is actually less optimal than the RGB system. So the light is darker, much dimmer. If you see the NBI of white light, the ENT scopes, they're dimmer than the colonoscope and esophageal scopes. It's because of this time. And the color CCD has a lower resolution and a contrast compared to the black and white CCD. But it doesn't have a flicker. So some people find it very distracting looking at the screen with the flicker images. Some people don't. Anyway, the newer system, they move on. They don't use xenon light anymore. They use LEDs. So they will use an LED to generate the different colors. So this system now, the newer system is better than the old one with xenon light. But I think a lot of places we haven't moved on to this new system yet. It uses the LED, it has the benefit of first, the bulb doesn't last much longer and less heat, and it's actually brighter. So this is the newer system where they actually use 5 LEDs now. So the 3 ones are for the white light, the RG, the 3 ones, the white light, and the blue and the green are specific for the NBI. So they use 3 LEDs for the white light color and 2 other LEDs for the NBI. So it makes the even better. So in terms of the color resolution and everything. But I yet haven't had to use it extensively to compare the difference between the two. Theoretically, it's better. I mean, anyway, don't jump and buy the new one. I mean, if you're going to buy a new one, then buy a new one. But if you have the old one, there's no urgency to jump and buy a new one. But you need to know the theory. Okay, so basically this is a summary between the RGB system and the white light system. The problem with the RGB system is it cannot use on ridges. It cannot because it changes the color. The ridges telescope. Also, the thing is when you use NBI on rigid telescope, sometimes it doesn't work because the glass in some of the telescopes are not optimized for RGB for NBI. They may absorb the color and didn't get you the contrast required. Whereas the flexible scope, they have the camera at the end of the endoscope. So you don't get that absorption of the light with the glass lens, and you will lose that contrast. So the problem with the RGBism is the flickering, but it has a higher resolution. So it's up to you. Some people find it very disturbing and cannot work in a flickering light. Okay, so the other thing you need apart from the light source is the close focus. So the whole thing about looking at the microvasculature is you'll be able to see the small vessels. There's no point when you do an NBI 5 centimeters away from the lesion because you can't see the capillaries. You can't differentiate the difference. So you need scopes that can focus close to 2 millimeters. Some scopes from Olympus have variable distance. There's a lever that you control the focus distance. So you can turn it and becomes much more focused. Some don't. But mostly the colonoscope and the OGD, so it also has a button that you press on it. It can focus close to 2 millimeters. That's what you call near focus. And from that, you can see the near focus. You can see the capillaries. That's an important thing. That's why a lot of times when I do NBI, I still like to take the patient to the operating room and put it under anesthesia or sedation and use a GI endoscope instead of an ENT endoscope. Because the ENT endoscope, especially some of the older ones, can't focus so close. You put the scope very close, you lose focus and you can't see the capillaries. Okay, and I mean, to balance it, I can't just say about Olympus. So there are other systems. The other one, I mean, mainly is Fuji. So Fuji has something similar, but they don't use the 2 frequency. They just use 1 frequency, the blue light. So it's very similar in terms of but it's just use a different wavelength. But they say it's the same in terms to accentuate the red, to show up the capillaries. So the Olympus, the Fuji system is similar, except it's using a different frequency. So I haven't personally used it. I can't tell you the experience. Okay, so what we are looking for in NBI, we are looking for abnormal capillaries, and then we go in and zoom in and see whether these capillaries are actually abnormal in terms of premalignant or just inflammation. So we need a magnified view. So first of all, we see on NBI, a well-demarcated brownish area. So you focus far away and you see this brownish patch, then you think, oh, this patch may be abnormal. And then you zoom in, well-demarcated, easy to trace border, not a very vague. Sometimes there's a lot of dotted vague, sometimes it's just bruising in the mucosa. And then you zoom in, you see this abnormal vessel where Prof. Sugimoto had just mentioned about all these abnormal vessels. It's first developed in the esophagus and the stomach, and later now we find the pharynx also has, and the larynx also has similar pattern. So these irregular mucosa, they are mostly, what you say is the abnormal ones are caliber very variable, very chaotic in terms of pattern. So if you see a patch, but the capillaries are still well organized and not chaotic, diameters are very, very uniform, it may be just inflammation, where the blood flow is increased. But it's the architecture of the capillaries. Okay, I'm going to skip that. So it talks about the different, predicting the different, from the pattern to predicting a different depth of the invasion of the tumor. Honestly, I found this very difficult. Very, very difficult. You have to be very meticulous and a lot of experience to see to judge from the mucosal pattern, the capillary pattern, to say whether this is invaded the muscle or if not. What I recommend is, if you see any abnormal, just biopsy that rather than using your NBI, unless you're very, very experienced in looking at the NBI. Okay, so you can see this is a normal NBI, normal papillary. These are normal submucosal vessels. This one is an abnormal one. You can see the different diameters, very chaotic, dilated loops instead of the deeper capillaries. The superficial ones are more brownish. The deeper ones are more bluish. Okay. And then this is a junction. This is the normal mucosa, and this is the abnormal capillary. Okay. So you can see the junction. So underneath, if you take it to a histo, the normal are the green ones or blue ones that you see are these normals of mucosal capillaries, whereas in the cancer ones, they have these loops that going into the mucosa. These are the ones that the chaotic loops that we pick up on NBI. Okay, so there are several types of IPCL from 1 to 5. If you're interested, I recommend you to read the literature from Uto. You can see basically the difference is from well uniform small loops to becoming more non-uniform, chaotic, dilated, and all the way very dilated vessels. But I would say for our use, or maybe for us, there's no need to subclassify all these. It's very difficult. All you need to know is this between this is good enough. Okay. If you recognize this, you don't worry. If you recognize this, you biopsy, or you're worried about this cancer. So these are also the ideal form, but it's never like this in clinical practice. So the normal loops versus the abnormal loops. See? Can I pass? Okay, thanks. Okay, so this is another pattern you can see, just show you the demonstration. This is using a esophageal scope. This is epiglottis. You can see the abnormal dots and irregular capillary loops in the area. So, okay. So in the OPD setting is a bit more challenging. First, you cannot use the fiber scope. The newer scope, the better because they're brighter. And you do a white light first, make sure there's no gross lesion, and then you do an NBI. Look for what I mentioned, the well-demarcated brownish areas. Okay, and then you also do what if you want to do, because especially in Asians or East Asians, Chinese, Koreans, and the Japanese, they are more prone to this type of dysplasia happening in the hypopharynx. So especially in heavy drinkers and smokers. So you do this what we call the Killian maneuver to improve the visualization of the hypopharynx. So you ask the patient to sit, head down, hold the nostril close about 10 salva. That will blow up the hypopharynx area, and you will see the prostricoid and the brevium fossa better. But sometimes it's not always possible. If there's the patient has to be very well anesthetized on the nose, because it takes a while to see this. But this is one way to see the mucosa. And then you can sometimes see this patch. This is actually from my good friend, Dr. Tateya in Fujita University. This is a white light. You can barely see a red patch, but you switch to the NBI, you'll see this well-demarcated brownish patch, which is the suspicion. But biopsy this area in the clinic may be difficult. You might need to bring him to the operating room to biopsy. Sometimes you can, depends whether the patient is cooperative. But some patients get a lot, and it's very difficult to do a biopsy. Okay, this is another peripheral sinus lesion. Closely, you can see a bit of red compared to this mucosa. The capillary, this looks a bit. But once under NBI, you'll see the abnormal dots of the abnormal capillaries. Okay, so what do we need? A lot of times I do these not under general anesthesia, but in the endoscopy suite under sedation. If the patient is unsafe, you do a GA, but if most of the fit patients, we can do it. We use the sedation because if the patient keeps falling or moving, you cannot see. So we sedate them, we spray them with 10% lidocaine spray, and then also spray the nose. And then we use a IV sedation with diazepam and petadine. You can use other things that means this is the best. You can use the propofol. We sometimes will give anticholinergic to reduce the saliva, because if there's too much saliva over the mucosa, it dampens the light and you can't see. You have to be quite dry, the mucosa. And we also add this GasCon. This is a thing that is you use it, it reduces the bubbling from saliva. You know, when you have air in the saliva, it bubbles, and the bubble will become steam. So you use this GasCon, add it to spray around the pharyngeal mucosa. It will reduce the bubbling of the saliva, and you'll see better. So we screen with white light first, and then we do NBI. Look for the well-demarcated branch patch. And then, if you have near focus, then you zoom in the lesion, you use near focus to see the micropapillary pattern. And remember, don't biopsy until the end, because a drop of blood will make your NBI completely ruined. Everything will turn brown. So try not to cause any bleeding. And if there's bleeding, you have to wash it away with a lot of saline. Otherwise, you cannot continue your observation. And then we will do a chromoendoscopy if it is a GI lesion. Chromoendoscopy is if it's under sedation, I do it in the esophagus. If it's general anesthesia, I'll do the whole pharynx too. So chromoendoscopy is very similar to what NBI is looking, except it uses a completely different physiological pathway. This time we are not looking into the capillary, but we're looking to the metabolism of the mucosa. So this is actually going back to the 1930s, where Professor Warburg got his Nobel Prize from the Warburg effect, showing that cancer cells have abnormal glucose metabolism. It gets its energy from glycolysis and not Krebs cycle, so it's very inefficient. So you need to uptake a lot of glucose, and will lead to the glycogen depletion inside cells. And you know, iodine will stain glycogen. So if the cell has depleted your glycogen, it will have become non-staining. This whole Warburg effect is exactly what PET scan is doing. PET scan is also seeing glucose metabolism. So we'll use this to stain the epithelium, and the dysplastic epithelium will show as unstained patch. I'll show you in the video. So, but the important thing is that glucose iodine is a very irritant subject. Irritant thing. So you don't spray them above 25 centimeters esophagus if the patient is awake. Otherwise, the patient will feel very irritated. So give you a burning sensation. And try not to spray into the airway, because it can. So if you do it, intubate the patient and try to put a piece of small patty around the larynx so that it doesn't overspill into the larynx, trachea. Otherwise, it can cause bronchial irritation and bronchospasm. So spray, wash, and spray again. I'll show you. And also remember, do your NBI before your iodine spray, because when you spray iodine, everything comes brown. Can you play this video for me? Hey, you go ahead. Oh, no, this is not a video. Okay, sorry, this is a photo. So you can see this is the iodine staining. I did this patient under general anesthesia. This is a small early cancer of the peripheral sinus. This is a small early cancer of the peripheral sinus. You can see after staining, the normal mucosa will stain brown, and the cancer part will become unstained. The alternative of using a flexible endoscope is to use this chip-on-tip rigid endoscope from Olympus. So they have this one called Endo-I. This is also NBI compatible. I like to use the 10 millimeter one because it's brighter, but the 5 millimeter is better for narrow spaces, which are smaller. I can use it under direct, but after direct laryngoscopy suspension of the larynx, you can put this scope in and do your NBI. So if you want to do an NBI in a patient in direct laryngoscopy, you have to use this instrument, or you can use a flexible endoscope. Okay, can you play? Okay. So this is a patient that I'm doing. This patient already, you can suspend it with the what we call a laryngoscope. A laryngoscope that can expand the whole area. So I watched it first with a lot of saline. It's under GA. So it's a patient at a tray. So it's under GA. So won't aspirate. You don't want. And then you rinse it with a lot of saline. And then you turn on your NBI. There's a little bit of bleeding from the suspension. So the blood, you have to really wash away the blood. And then you see a brownish patch around this area. This area, a brownish patch. And you zoom into near focus, you can see the near focus is here. And you can see the normal patterns. You can see this. So Let's keep going, keep going. Yeah. And you can see the normal actually extends over here. This is the normal part. You can see the greenish, bluish normal capillaries versus the red, brownish, and normal capillaries. So you look for the entire extent of the lesion. Because it is also abnormal over here. So this is normal. This is abnormal. But you need the near focus to closely magnify to see the abnormal. This is abnormal. And this is normal. This is the junction. So it's much more wider than your white light can see. It's actually the whole postcrical mucosa. But these are dysplasias. Biopsy shows carcinoma in situ, not invasive cancer. Okay, I was taking a photo. That's why I froze it. Okay. And then now we will. This is the esophagus opening. You can see a bit of reflux of the contents. This is done with the upper GI endoscope. And then I'm spraying the stringent by white light. I'm starting to spray through those RD. So you make sure the cuff is well inflated. The patient don't aspirate the RD. And then you just spray, make sure you get a very even coverage of all the mucosa. And then you wash the excess with water, with saline, wash away all the excess, and wait for a little bit, and you can see the unstained patch. You spray again, usually wash and spray again, so to increase the contrast between the normal and normal mucosa. So you spray again. Actually, your GI physician would say they have all these things. They do it all the time in the stomach and in the esophagus. So they have all the equipment. You just have to do it under GA for our ENT part because of the irritation. And you can see the non-staining of the postcricoid area. This is not very well accentuated, but there's a bit of non-staining. So we go to the next video. Is it a single? Okay, so who to screen? It's difficult to screen everyone. We recommend screening patients who have high risk of developing a second early dysplastic lesion in the pharynx and the larynx. So esophagus cancer survivors, heavy drinker or smokers, patient with multiple dysplastic patches in the esophagus, and other head and neck cancer survivors, maybe. But the problem is, it's more difficult to differentiate these patients in post-radiated patients. Post-radiated, they have these abnormal telangiectasia, which is, I find it very difficult to interpret between normal and abnormal compared to a non-radiated patient. Finally, the future is AI. Can you just click the video? Yeah. So this has been approved for rectum, for colorectal cancer. So because it's so difficult to capture these patterns, they actually now use AI. And there are multiple companies selling these AIs for colon and colonoscopies. So you just touch the lesion, and then they'll tell you what's the percentage of the lesion being benign or malignant. So the AI will recognize the pattern for you. So so this is using, they stain it with methylene blue, and they can see that normal, and they'll tell you the risk of being neoplastic. The problem with head and neck and ENT is we are much smaller volume cancer than colorectal. So there's no financial incentive for these companies to develop these AI for us. But this is another one. You can see this is I think it's a stomach. This is or colon. I don't know. You have to touch it, look at the pattern, magnify it, and then they'll tell you how many. Yeah. So in the future, we'll move on. These will be AIs, and maybe staying with different things, and they can all match up. And I think it's now routine for the colorectal people to use AI to screen for colonic polyps. Okay, I think this is yeah. So thank you very much.
The next lecture will be by Dr. Rakesh, will be on the webinar. And thank you, Dr. Rakesh. We're gonna set you up on our Zoom meeting.
So thank you for inviting me for this lecture. That is, my lecture is based on narrowband imaging, preoperative and intraoperative NBI in laryngeal cancer during transoral laser surgery. So I am Dr. Rakesh from Lucknow, India. I will be sharing my experience, and thanks to Dr. Raymond for giving an insights about few important features which will be included in my presentation. So when we do the scopy, we go as close as possible. The trick of the scopy is rotation of examiner's finger, and rotation of patient head. Clearance maneuver to look for the post-cricoid area, including the Valsalva maneuver to see the post-cricoid area. Adjusting the enhancement and brightness. Do not touch the mucosa. Scope gently and ask the patient to breathe slowly. If severe gag or unable to get a close shot, use 4% xalocaine. Careful in case of compromised airway, allergy, or bronchial asthma. But for the operative assessment, these are the few points which are important. Use Adrenaline soaked patties and irrigate with saline. Do suction over the patties, not directly over the lesion. Use 30 or 70-degree telescope when needed. Use a vocal floor spreader to look for ventricle or postglottis. Concentrate more on the surrounding area and the satellite and synchronous lesion when we are assessing the primary site. Mobility of cord is important for staging the disease. So how to report it? We have to look for the second primary, that is hidden areas like vallicula, base of tongue, lower pole of tonsil. Laryngeal lesions can be classified on two grades. That is, one is knee classification, other is ELS classification. Knee was given in 2011 and ELS in 2017. It's a site-specific classification. You can classify into various sites. Multiple pattern report like site-specific and pattern-specific. Comparing the knee classification with ELS classification, A1 pattern, if we look at the knee classification, there are A1, B1, C1, D1, E1, and F1 and G1. So these E1, F1, G1 are classified as type 5 pattern, and these are basically 1, 2, 3. When the new angiogenesis starts, it starts with dilatation of the capillaries, and then small brown dots will be there. So these block E1, F1, G1 are suggestive of squamous cell carcinoma. And these are the changes which we see on ELS classification, that is longitudinal vessel arrangement and perpendicular vessel arrangement. Any change in the perpendicular vessel arrangement will be suggestive of malignancy. So there is a gray area, whereas the pattern 4 will have a perpendicular vessel arrangement with fine brown dots. So that is how I compared both the classifications, so that you will have a clearer picture of what I am talking of. So these are the close view which we normally take with the scope, so as to get a clearer picture. These are the heat maps. We take it for our AI work. So in-office assessment, this is an image which is taken from a distance. Then again, we have gone closer to the lesion. Again, closer to the lesion. Here you can appreciate there is a false chord, which is almost covering the true chord. And at the anterior commission, it is very difficult to see whether it is getting involved into it. So in these cases, we normally get the imaging done to know the extent of the tumor, whether it is resectable by transfemoral laser surgery or not. So this is the advantage of using a preoperative assessment using NBI. Now regarding the surrounding secretions of saliva, sometimes it's obscured the primary lesion. So what we have to do, we have to use a white light scopy for differentiation, suck out the saliva and look again in the NBI to know the pattern recognition by NBI, because the surrounding area around the keratotic patch or a leukoplakic patch gives a lot of information as compared to the primary site. So enhancement and contrast also, sometimes there's a white light, white out, and sometimes there is a reflection because of the brightness and reflection from the saliva itself. So then we have to adjust the enhancement and contrast. And one picture might have a two type of pattern. Like in this lesion, if you see the small brown dots are there, there is a keratotic patch on the other cord also there. So our focus is mainly on the surrounding area where there's a white patch is there, so that we can know about what type of leukoplakic patch we are dealing with, whether it's a flat white lesion or it's a raised white lesion. So closeness improves the pixels. So that is the crux of it. What Professor Raymond has said about 2 mm is a distance which we can capture the image. So in office also, we can go it very close to the lesion using 4% xylocaine goggle. So type 2 pattern, if you see here, you can see there is the arborescent capillaries are there, and there is a small whitish patch is there under the white patch. There is a capillaries, you can appreciate it. Type 2 pattern is an umbrella pattern where we can see there is a peripheral capillary vessel, which is going under the white lesion, and it can be seen as a transparent area that the capillaries are getting, and the tortuosity is there, which is appreciated in this. This is type 3 pattern. Again, on the other side also, there's a leukoplakic patch is there. So this is known as umbrella effect, where the findings are hidden. Type 4 pattern, again, it is like, if you see it here on knee classification, there are capillaries which are going like this, and it is breaking into small fine dots are there. And these are suggestive of moderate to moderate dysplasia. So the peripheral part is very important. Now, this is an interesting case of operated right vocal fold squamous cell carcinoma. Post-operatively, there will be some changes on the white light, but finally we got into NBI, and you can see there is a small brown dots at a very close proximity to each other. Low density, and this is suggestive of mild to moderate dysplasia. Again, this is another lesion where we can see there's a leukoplakic patch is there, and surrounding area we can see appreciated. There is a so this is again the assessment under general anesthesia, the intraoperative assessment using narrowband imaging. Here you can appreciate that it looks like a right-sided lesion, but if we closely examine it on the other cord also, we can see there are some changes are there. On shifting to NBI mode, we can see there is a fine dots are there, which is suggestive of moderate dysplasia. The other side also cord, you can see the small brown dots are there, which is again, which has missed out in the white light scopy. Type 5A pattern where there's a brownish, bigger dots are there, but they are widespread, like this one. Sorry. And if you see there is a bigger lesion on this side, right cord, but in the periphery, you can appreciate there are lesion on the surrounding area. Then there is another lesion like on right arachnoid presenting like a snake and earthworm or a tadpole-like branching pattern. This is suggestive of type 5B pattern. So one patient might have a different type of pattern in the same lesion, but we have to report it to the highest grade of it and specify it when we are reporting it and sending it to comparing the result with the histopathology. So this is type 5B pattern. Now type 5C will have a slough-like structure because all the blood supply has gone. So this is clearly demarcating. So one lesion may have a multiple pattern like this one. And there is a impact of NBI imaging on pre and intraoperative assessment of neoplastic and pre-neoplastic lesion. It is a systematic review of 14 articles. The sensitivity, specificity, and positive and negative predictive values were compared. Accuracy is better in intraoperative NBI as compared to preoperative NBI. And this was a comparison of that various studies there. The maximum cases which has been taken for this study is by Professor Piazza from Italy. And what he has suggested, the sensitivity of preoperative NBI is 61%. And if you see the specificity of it, it is intraoperative NBI has got 98%. While the accuracy is, again, it is more than 90% in both the, comparing both the series with comparing the preoperative NBI with intraoperative NBI. These are my studies on various assessment using extended application of narrowband imaging in chronic granulomatous laryngeal tuberculosis. The comparison of pre-malignant, early malignant lesions in transglottic early malignant lesions using NBI. In my study also, there was upstaging of tumor is there, which is being missed out in preoperative NBI. And there is an article which was published in 2015, almost 10 years back, which compares the intraoperative NBI imaging better delineates the superficial resection margin during transoral laser surgery for early glottic cancer. And so preoperative assessment, palpation is very important. Pliability and island of intrapapillary capillary loops. So now we have taken a snapshot to keep it, because once we shift it to microscope, it is difficult to assess the. So here we can see there's a little bit of bleeding was there. But here we can see the pattern is there, which is earthworm-like pattern, which is suggestive of it. Now we have opened the ventricle to look into the lateral extent of the tumor, so that we'll have certain idea about the lateral dissection, which we can do it. So hydrodissection technique has been used to remove the tumor. These are the difficult cases. I thought I'll share it with you because these are the cases which we encounter in our area, in our country. So these are the false positive cases suggestive of malignancy, but these are the cases which turned out to be a tubercular laryngitis, presented like a granulomatous lesion, ulcerative lesion, but not showing any classical pattern of malignancy. So these were later turned out to be a tubercular. So no IPCL pattern, inflammatory changes, tuberculosis of the larynx. again an intraoperative assessment. Sometimes it is very difficult to assess it, like this lesion is there. So the limitation of NBI is when the mucosal surface is intact and the tumor is underneath the mucosal surface. So it is difficult to tell about the intrapapillary capillary loop pattern, but this leukoplakic patch is suggestive of invasive tumor inside this ligament. And then we did with a palpation of the tumor so that we have a certain idea, because if we take a biopsy also, it will come out to be a negative. So limitation of NBI is when the mucosa or the submucosa and is intact and there is an infiltrative tumor inside the muscle plane. A difficult exposure patient like this one, this was recently done because the false cord was covering the anterior commissure lesion. So what I did is we opened the false cord to have a clearer look of the. So we removed the false cord to have a, and then again we examined it with NBI to have a pattern recognition using a contrast enhancement technology. Irrigation and then using a, so after the blood comes in the field, it is difficult to, so this is after the resection of the tumor. So this false cord has gone. Now we have preserved almost part of the ligament and did a type 2 on the right and partly on the left side also type 2 cordectomy. So conclusion is preoperative and intraoperative staging is essential. Use of angle telescopes, irrigation and mopping in case of bleeding due to intubation before the assessment. Image segmentation and margin demarcation essential for good results, because once we shift to a microscope, it is difficult to assess the margin. But if we use a higher magnification with microscope and zoom in images, we can do the dissection very well. Taking a snapshot before shifting to microscope is a wise decision. I'll just show my own comparative study of preoperative NBI and histopathological comparison in single stage laser surgery, in which we have done 79 cases. Total, the majority was male. Total number of lesions which we assessed is 107, and which we compared the results of our NBI with histopathological correlation, in which we have seen that the upstaging of the things are there, because even what we have reported in peroperative NBI, in histopathology, it came out to be the incidence is slightly higher. So this is again a table showing the result of results. So jump from moderate to squamous cell carcinoma is there. So high definition contrast image enhancement technology have changed the management concept for pre-malignant and malignant glottic lesions. The concept of single stage transfemoral laser surgery was introduced by Blacksley and Paretti et al. In selected glottic cancers. In mid-glottic lesion, we follow the same concept. If the tumor is not involving the paraglottic space and not going into the anterior commissure, we can still doing single stage surgery. Interpretation of these lesions depend on endoscopist experience. False positive, false negative are still a concern in country like India, where the granulomatous cholangiotuberculosis is high and it gives or mimic a picture of malignancy. Limited surgical excision with voice conservative TLM is possible due to these technology. For further read, you can go to my book, which is Atlas on Narrowband Imaging. Thank you very much for APOST for inviting me for this lecture.
So let's start the last lecture about laser in laryngology. Something happy to tell you that there are some overlaps with some students. So this 20-minute lecture will be shorter than 20 minutes. Thank you. So yes, I'm John Lee from Hong Kong. Today we're talking about mainly in-office laryngeal procedure on laser. Just disclosure again, we have no financial interest with any company mentioned. Laser are powerful instruments. Remember to know the properties once you buy your own laser machines, because the property will be different. This is my personal application and my personal experience. So do ask your attending physicians to tell you about their own tips. Objective for this presentation will be about basic use of the laser physics, introduction of the in-office laryngeal procedures and their settings, the procedure, how to set up the office laryngeal procedure, and then to discuss application on mainly benign lesions. So as we have mentioned that the laser in laryngology was started by Patel's team in 2004, treating the recurrent respiratory papillomatosis with laser in his office. Due to the high definition chips on the laryngoscopic tips and fiber, there are more widespread of use of endoscopic assisted laser procedures in laryngology. So there are lots of benefits during these years. We've noted that you can decrease the mobility and inconvenience of patient compared to the general anesthesia to our traditional direct laryngoscopy procedures. So you know the acronym light amplification by stimulated emission of radiation means laser. And then you know the properties, the 3 C's, the monochromic, one wavelength, coherent, or in one phase, and collimated in one parallel wavelength. So the power, the wavelength, the power density, and the tissue characteristic and exposure time will actually we'll actually see how the tissue has been burned. So the white part with the burn part, the volume that's been cut blade, red part will be coagulation part. All different lasers have their own area of edema or collateral damages. So we talk about in later stage, but mainly on blue laser. But different lasers like CO2, KTP have their own properties as well. So mainly in the laser of choice in laryngology would be finding a laser that is photoangelitic, which are the 585 PDLs, 532 KDPs. The cutting property would be the 10x600 the CO2. And then the 445 nanometer blue laser blends both of these properties together. That's why I chose that laser. As you can see in this chart, the 10600 will be all the way to the end of the right side of the graph, which the property that's been absorbed by these CO2 wavelength will be the water, the maximum one. And then the KTP will be the hemoglobin, pulse dye will be the hemoglobin, and then the 445 will be around here, the blue laser, which absorbs hemoglobin and the water as well. It's absorbed by the water and the hemoglobin. These are the mainly laser machines that you'll be seeing in your clinic. The bottom one would be the luminous ones. And then the top one, right side, top right-hand corner would be the KDP. The top left-hand corner would be the ARC blue laser. Settings. So laser settings is my experience for the CO2. So I set mine at the super pulse, repeated. 5 watts. I think 5 will be enough for our laryngology procedures. But the machine asks us to set 10 watts, but I think 5 watts would be better so that you don't burn them. The spot size, depending on how big you want the laser, how big the lesion is, that your own preference. I set on the 1.5 millimeters, and then the depth to the on would be the power and the super pulse part, and then the off part would be the time that the laser has heat will be dissipated. So we will be setting more than 0.3 at most, at the least, in my experience. 0.2 is too short, so that the heat dissipates, so that the heat does not collect in the tissue, so that the damages increase while watts is increased as well. The true blue, the maximum watts for the true blue laser by ARC is 10. So this is actually mostly done used by the dental, which the maximum power would be 4 watts in the dental laser machines, but this is a 10 watts. They recommend you starting off with 3 watts first, then slowly increasing to 6 to 8, and then 10 would be the max. So again, back to the in-office laser laryngeal procedure again after Dr. Suda. Same, I agree totally with her slides. So we would jump from some of the slides. This is just to avoid the morbidity that's associated with the general anesthesia, and then the damage that would be caused inside the oral cavity during the suspension laryngoscopy, especially at the anterior pillar, where then there's lots of hair, where the mandible is short and the patient could not have a better exposure of the larynx. This happens when we are trying to turn that Lindholm laryngoscope up high to see the larynx. So there's some tear over the laryngoscope at the anterior pillar. And then because of the factor, the mouth to the larynx is not straight, then there's some challenging difficulty with the rigid endoscopies. And then also saving the institute of the GA time and the time where then the patient might have to stay a day because of the general anesthesia. With the office laryngeal procedure, it could be a day surgery. So it saves time and money for the patient and the hospital. The case selection. So wide range of benign laryngeal disease are included in these case selections, such as telangiectasia, where there's only some blood vessels seen on the vocal cord, recurrent respiratory papillomatosis, vocal cord polyps, vocal cord granulomas, vocal cord cysts, Ranke's edema. These are the benign lesion that I started off with, and then sometimes maybe some early tumor like a T1A tumor, you can do it through the flexible laser as well. Case selection about patients. So the patient we will talk about that later and after the slides. After this slide. So I'll just start off with the benign laryngeal lesions first, so that you can do it by stage. Once that lesion is too big and the patient cannot tolerate the procedure. When mostly these patients could only tolerate around 15 minutes to 20 minutes. Some radiated patients like nasopharyngeal carcinoma patient, whether they have neck radiated, they might withstand longer, around 30 minutes, 45 minutes, but mainly 15 minutes. So you have to really time that clock. Once you put that topical anesthesia, 50 minutes is the time duration where you want to finish off the procedure. Of course, if there's a high risk patient for general anesthesia, as a recent myocardial infarction or stroke as well. Contraindications. So again, I said I would talk about the patient selection. So if the patient is not tolerable, not tolerating your flexible and laryngoscopy examination in the office without the local anesthesia. So in Hong Kong, we don't spray the nose with the local anesthesia nor the adrenaline. I know the Western and the Singapore colleagues will have adrenaline and lignocaine in the nose and the throat. We don't. We just do a fast flexible laryngoscopy examination of the throat, and then we'll see if the patient tolerates. So if it's gagged a lot, then these patients would not be tolerating the in-office laryngeal procedures. Of course, significant anxieties whether the patient so scared that they have to ask every time. Every time they deduct the vocal cord, it's very hard to shoot the laser over that lesions. Port anatomy, maybe there's been some robotic procedures being done, or there's some radiation being done in the neck, or obesity within the neck to fat. They might distort the normal anatomy, whether the flexible will be flexed even more, so that you have to stay at that position. The thumb will be very tight. It's very hard to perform with those patients. But then some poor function, where then oxygen is required, because one still keep the oxygen percentage low, so that although there are no burn, if you have a fire, you need some energy, something to burn, and some oxygen. There's nothing to burn there, but you still want to keep it low because the nursing staff will be scared of airway fire. If the lesion is too bulky. But once you are more confident, you can still do some bulky lesions while you stage them. So you can stage it to 1, 2. It will be much smaller than the first time you shoot at after you shoot the laser, because it will shrink. So you can stage it once you see these bulky lesions and the patient is not tolerable for GA. Uncontrolled hypertension, because once the systolic pressure is high, it starts bleeding, and then once it starts bleeding, your CO2 or your blue laser will power will get absorbed by this blood, so the power will not actually go to lesion, so you can't ablate the thing. So it's hard. It's much harder. Allergy to lidocaine, of course, this is simple. Reasons ischemic heart disease, because recent heart disease will be contraindicated at GA as well, right? For the LA procedure, some papers stated that the LA procedure will cause some stress to the heart. So you have to talk. You have to go through these patients to see if these recent heart disease is actually actually contraindication or just relative. If they don't speak your native language, so you can't communicate with them, you can't actually calm them, because I don't use nebulizing LA, as I thought from said that nebulizing local anesthesia is better. I do agree with that. One, I was learning off the our Western colleagues. We use nebulizing LA. They can get numb very easily, so that they won't actually choke or something like that. But then if I think verbally calming the patient is also a very good anesthesia, because once they calm and then they get reassured, they don't move a lot. And then we started off the procedure during the COVID period, so then we talk about these safety procedure, because it's an aerosol generating procedure. So I reckon you to have some personal protective equipment with a good ventilation room. So at that time, we had to test the patient every 3 days, 1 day before 72 hours for COVID tests, just to make sure that the patient has no COVID. And then the local anesthesia room was chosen because they have the HEPA filter. And then, of course, the crash cart should be nearby. Touch wood, at this moment, the whole world did not have a very major complication for these procedures. Documentation is just for, of course, informed consent. I suggest you to do some pre-intra-op, post-op vital sign recording as well, so that you know that if the patient's having the complications. And then chart the topical anesthesia dosage that you use, so that when you do have some problem, you know what's going on. Through the nose, through the mouth, and through the scope to the laryngopharynx as well. Laser energy settings and the pulse wave, so that you can actually monitor what your procedures are going through during your patient's follow-up. And then again, around 50 minutes after the procedure, not eating and drinking is enough already. And then I'll let the patient go after the last vital observation after 60 minutes. Setup of the machine, it's very personal. You can do it by your own way, but I like it all in front of my patient, so that I can see the patient. At the meantime, I can see the laser setting and the video scopes, the video tower, the monitor. So because I want to see if the laser fiber is connected correctly, the power settings, and then all my local anesthesia would be placed in front of me so that I know how many I've been using. So I just in my beginning of the practice, I use 1% so I can use a larger volume. But then through time, I think a high percentage would be better because my mentor uses 4%, and I think Singaporeans also use 4% here, right, as well. Last time, 4, 2, 2. Oh yeah, because 4% is very hard to get in Hong Kong, and I think it's much better in inciting the patient because 1% of lidocaine gets used more, but the patient still chokes a bit. So now we're trying to source 4% as well. So yeah, and then the laser safety procedure. We talked that in our the hands-on workshop as well. But then it's very important to have a door signature so that the patient, the staff in the OT theater knows that the laser is on because of the laser leakage is very, very important and dangerous. Laser protective specifically to the laser glasses is also recommended. All our medical laser are unsafe to eye, so they are very high classes for class 4, so that they will damage the eye. Again, laser specific goggles are needed, so therefore you have to see at the side of the goggle where then they have a range of wavelength that they actually protect, and then you have to check your laser wavelength if it's inside within that range. Laser checklist, because we don't want any leakage of the laser, door should be closed. If there's windows, the blind should be down. External lights so that external staff know that the room OT theater is having laser going on so that they don't go in. And then if they want to have to go in, they have to find a laser glass, safety glass. Again, the nurses will always be afraid of the airway fire, so therefore you have to keep a saline syringe or a copious amount of water or saline next to your procedure. And then to check if everyone's wearing, even the patient is wearing the safety glasses. Anesthesia. So we can't use nebulizer after the severe acute respiratory syndrome. And can't remember which, I think it's 90 something. Even after the COVID, I think the whole world would change not to be able to use nebulizer. But I think nebulizer is the best. They can actually numb the patient for 30 minutes and more, and the patient would not move at all. So the Americans like to do it for the RP. They just ablate all the papillomatosis that they see through the scope. So what I use is cofenalcaine, which is a mixture of 5% lidocaine, 5% of phenylephrine, 6 sprays, so 3 sprays to each node. That will decongest and anesthetize the nose. That's my personal thing. You can use your adrenaline and 2% LA. That's also equivalent, I think, also best. And then 10% lidocaine, 6 sprays, 1 spray to the left antipillar, 1 spray to the right antipillar, and then 2 spray to the posterior wall of the oropharynx, and then 2 spray where you bend that catheter anteriorly so that you hit the larynx. That actually helps a lot. 1% lidocaine, 10 mils, and then we just slow dripping through the adrenaline catheter that we mentioned before in the first presentation. Here, because all my mentors, all my Hong Kong mentors will wait for 15 minutes, so I still put that on. But I think once you finish dripping, you start your clock because I just have 15 minutes, right? So after that 15 minutes, the patient will be not probable. So I think you should start right after you finish dripping. I would like to test the patient's sensation before I start so that I know that it's well anesthetized. So I touch the epiglottis. And that's the most sensitive part. If it doesn't move, if the patient doesn't know, then you can ask the nurse to give you the laser fiber ready. So this is the picture to show cofenalcaine and then the percentage that it's sprayed. 10% lidocaine. So you have to know that each spray includes each spray is 10 milligrams of lidocaine. So it's easier to calculate for your max dose. Adverse effect is the repetition of the slide of Dr. Pamsuda. As I've mentioned, there are only some minor complications as reported. I will mention that in next slide and this slide, about anxiety, intolerable, gagging, coughing, nausea, vomiting, vasovagal, and discomfort. So that's the most minor complication that's been reported through the research. And the major ones, lidocaine toxicity, methemoglobin, laryngospasm, is very rare. The Canadian team, the Anderson team, has actually done a paper about that. The major mortality was 0%, which includes mortality. Major complication is 0%, includes mortality, laryngospasm, air bleeding. Minor will be the vasovagal that's mentioned, at 4.1% only, mostly vasovagal. And hemorrhage 0, patient intolerance 13.1%. So therefore, in conclusion, in office laryngeal procedure is a well-tolerated procedure with low complication rates, and yeah, there's just some limited complications. So this slide will actually contradict with maybe a thought from Suda, but still, if you go online, there's no specific number of max dose like what you've injected in the skin. There's a magic figure of 3 and 7 with lidocaine. 3 would be the pure lidocaine, 7 would be with adrenaline. That's the magic number for injecting your skin. But if you go back, search, and see topical maximum dose for lidocaine, no one agrees upon a number. They have a range, a large range. If you remember what Todd from Suda said, it should be around 3 and 7 again as well, right? For lidocaine and with adrenaline. So because it's topical, there's no ENT paper that mentions that. I went on to the respiratory or the CTF society, where they do lots of fractional bronchoscopy. And they mentioned that it should be around, let's see, 15 something, 0.9 to 15.4. That's the range. So I just take, let's say 0.9. It will be with a 70 kilogram patient, it will be 490 mg. 15.4, it should be 630 mg. Just to be on the safe side, I use the latter one. But if you go to up to date, it's 5. It's just 5. So yeah, I just use I've used the 9.6 because this is a British Thoracic Society. If anything happens, I can go back to this society and just take this reference for the judge. So I used around 9 mg. So until now, again, touch wood, there's no complication yet about the toxicity. But you should remember again, the next slide, lidocaine toxicity, you have to know, since both of speakers mentioned it, and it's very hard to tell the judge, I don't know. Yeah, so what will happen? SAMS or from Susan have her own tips, will be as for slurring of speech, A will be altered state of the nervous system, M will be muscle twitching, and then S seizure. So the last 2 M and S will be the very late stage already. So once the patient is very drowsy and talks very slowly, and because you're still, I suggest you to keep on talking with the patient. Oh, it's very good. Are you okay? If you just give me a single word answer, then you know that this central nervous system state. Yeah, once it's drowsy, he or she's not answering properly, then you know you have to think of lidocaine toxicity, because you don't want to go to twitching and seizure. Yes, yeah. So once you see that patient drowsy, you might have to give him 100% oxygen, or he or she 100% oxygen. Just give them a benzodiazepine, just in case the seizure happens, right? And then maybe you have to have an ICU care, just on the safe side, because you just want yourself to be happy, the patient to be happy only, right? So yeah, on the safe side, you might have to call the ICU if you see the patient having slurred speech and low mental state. And then methemoglobin is just the diagnosis that you see, and because most times you'll be having the saturation going on during the procedure, so you know the saturation anyway. So once the concentration of the methylene hemoglobin is 0.3, there's no symptom, 10%, 20%, there's some cyanosis. So that at that stage, you'll be giving the methylene blue, 1 vial. Again, for all crash card, I think you all know, anything in crash card, it should be one dose of vials. So if you can't remember, just give a dose, 1 dose of the vial. Just express that the vial of methylene blue, give it a dose. But that this is a competitive inhibitor, so you have to give every maybe 5 minutes or so. So again, this you just have to know that you have to give methylene blue for methylene hemoglobin. Okay, this is the important part, but then you should know, would there be laryngeal spasm? Because we're not giving sedation. Yeah, in my locality, you can give sedation, but then once you give sedation, there might be some problem. Because laryngeal spasm only happens in general anesthesia. This is a well-known complication where then they give light general anesthesia, i.e. they're not fully anesthetized and they're not fully sedated. Then they have this partial reaction during the irritation of the general anesthesia, and the patient's accumulating these irritated reaction. Then once the GA procedure is finished, the reaction comes, and then they undergo spasm. But because our patients are awake, they can still cough. As I told you, there's 15 minutes, they cough, they choke. They have this airway protective mechanism, and they will not go undergo laryngeal spasm. Analogy would be you would aspirate some rice or some small parts of the food into the airway, right? And you just cough, cough, cough. You cough for around 10 seconds, and after the aspirate the peanut or the rice has been coughed out, you still have the foreign body sensation. You just want to cough, but then you won't undergo a laryngeal spasm. So again, laryngeal spasm should not occur. But if they start having some noisy breathing and stridor, so you have to think about giving the patient oxygen to sedate the patient more, and then to do some intubation. Yeah, but then that is if. Okay, so are there any limiting factor for the in-office laryngectomy procedure, especially for the laser? Yes, the cost of the fiber. I'm not sure which the cost for every company, so you have to ask about the cost of the fibers. And then the absence of the technology in your locality. So the blue laser might not be in your locality, or the KTP might not be in your locality. So you have to find a substitute. And then poor hemostasis, and then unprotected airway. So if the patient is very irritated, having asthma, undergoing asthma, just don't think about doing the laser procedure for these patients. So how I do it. As I mentioned, there are 2 choices that you have to think about: cutting, ablation, or photoanalytic property laser. So I just choose blue because they just have both properties. And paper by Hecht, a German laryngologist, he has done a study showing that the blue laser have absorption 10 times more than KTP for the coagulation property. So if you actually set the setting to a lower setting, around 1 to 3 watts, then the laser can actually coagulate and stop bleeding more better than the KTP does. And then because it's also water absorption for blue laser, it could cut with higher power, 6 to 8 watts as well. So that's the end of my lecture. So down to the Q&A session. Could you? Thank you. So are there any questions from the floor and the audience from Zoom as well? And then from Zoom, we might have to type your question through the chat box. For the audience here, you can ask for a mic so that the Zoom audience can hear as well. Any questions? If no, I'll maybe may I add a good hat? Sorry, Susan.
Yes. So
I
the
thought-
question is, how many times can we go through the injection of the hyaluronic acid and how long can we give it to the patient? Okay. Yes. Yeah. So, well, this is an interesting question. So every injection, the HA, is, well, I think it's feasible. Okay. But I usually don't do that much because once when you get a temporary injection, you're not gonna know that it lasts about like maybe 6 months. Okay. And after that, if the pathology is not reversible, you got a permanent injury to the vocal fold. Okay. Well, you might want to shift to the more permanent surgery, like Gore-Tex or block, silicone block, like pteroplasty. But yes, I have some cases that they ask for just like injection, but I found that is when once the HA get in that paraglottic space, even though it's like resolved, okay, it will leave some fibrosis in that area, so you can inject again, but with less than the first time. Okay, but yes, you can. But normally, usually we don't do that. Yeah. Okay.
So any question upon hyaluronic acid for injection or capacity from the audience? Yes.
Hi, for cases with the unilateral corporal paralysis with a more prominent phonation gap posteriorly, which approach would you usually prefer?
Well, I would shift to the, well, usually with the large gap, that will be, there's a prognosis that it might not come back. Yeah, like a total resection of the nerve or very, well, neuroplasia. Well, it's not neuroplasia. Usually, it's kind of like more injury. So I would shift to do an augmentation with the Gore-Tex or the silicone block if I got a large gap, and maybe might consider to do that arytenoid adduction together with the therapeutic, especially in a high vagal injury. Okay, well, you may want to do that because to close like to complete to close that gap. Okay, otherwise the voice will not very satisfied for the patient. Yes.
Can I ask you a question? Good. Any questions about hyaluronic acid? Or I want to have a follow-up question for the injection of capacity. Do you use other material for temporary injection of capacity?
Well, I would say fat, although that fat, but I need to get the patient under general anesthesia to do that because I consider fat is not a permanent thing, okay, but it's like unpredictable things. Okay, you can have that last longer, but you can have that like for just a month too. Yeah, so my selection is like fat, although that fat. Yeah, even though it lasts longer and the patient get their voice back, well, I don't see any problem doing the fat, okay, because it's really resolved eventually. Yeah.
And then have you tried using radius calcium?
Because in Thailand it's not indicated for vocal cord injection. Well, there's an indication for cosmetic surgery, but when I try to get it done, okay, well, let's say the company won't sell it to me, okay, so they're kind of like, this is not indicated, so it's not one allow that, okay, but I usually when I practice in my fellowship in Toronto, okay, we do that under general anesthesia. It's quite good. Okay, it lasts about more than a year. Like well, I think it's more than 18 months that they clear, more than that. Yeah, but you need to be careful because you need to inject in the right level. If you inject too superficial, it's gonna be in the Laryngology space, and you will get a fibrosis from that. So you need to be careful for that. Okay, so under generosity, it might be a better idea to get in the right spot. Doing in the office, you can do with the radius, the calcium advertised, but when the patient cough, it might leak. Okay, and it might too superficial.
So no, thank you, Susan. So I see a second question about NBI. Am I wrong? Am I right? About NBI. After the injection, HA injection. Yes, here we go. So let me see. Maybe Dr. Raymond? Yeah, there might be a question for you.
Yes.
So the question is, NBI report is good enough to go ahead with the necessary intervention?
No, I think NBI just allows me or where to biopsy. I will always biopsy because even though, I mean, maybe the very, very good can differentiate between mild dysplasia or inflammation versus intermediate or severe or carcinoma in situ. But otherwise, I would say use NBI for biopsy purpose to target where the biopsy, and secondly, I use NBI for resection margins. That one is good because the NBI can see the normal and the abnormal mucosa, and then you design your resection margin 2-3 millimeters from the abnormal mucosa is already good enough. So in gross resection, when we don't have NBI or don't have magnified scope, I take 10 to 15 millimeter from the lesion as margin when we do open resection. But with endoscopic resection, the NBI can let you determine exactly where are the margins to be resect. But for any intervention, I think we still need histology.
Yes, I totally.
And also, by the way, NBI doesn't work for HPV or pharyngeal cancer, and also other like minor salivary cancer and nasopharyngeal cancer are not that well described. All the IPCLs abnormal are only for swelling. Okay.
Yes, totally agrees. This question from the floor.
You mentioned you use NBI to guide your resection margin.
Yes.
So I assume for TLM TOS, how do you switch between the robot, the microscope, and the...
Okay. Actually not difficult. Sorry, it's a little bit sounds like a bit of advertisement. So I do something called ETOS. What we call ETOS is endoscopic TOS. So I start off with the patient under anesthesia, and then I put in the mouth gap, and then I use I'm talking about HPV negative oropharyngeal or hypopharyngeal lesion. I use an OGD, esophageal scope, go in, do the NBI, sometimes even with glucoaldehyde, and then I use a diathermy probe to mark the resection margin. And then I take away the endoscope, dock in the robot, and you already have a margin that you know to start to do. Same for TLM. Actually, the Italians have published a lot on using NBI for TLM for laryngeal lesion. So they will use usually the endo-alpha, the rigid lens, put in after suspension laryngoscopy, put a rigid lens, and then use a diathermy needle or something long to mark the margins, and then come out and put a laser in and then reset according to the margins.
Yep. And that's the second question.
Yeah. For the resection margin intraoperatively using NBI, do you still send a frozen on table for confirmation regarding the margin? And if no, post-operatively, what is your experience between the surgically margin clear versus what you see?
Good question. Now that goes back to the technique of endoscopic resection. If for the specific type that we use to use an NBI, I do not do frozen section. But actually, frozen section are not sampling errors. Because but I will pin the lesion, mount it, orientate it specifically, and then send it to lab. If it turns out there's a positive margin, there are two options. Either you go back for resection, which is possible, or because if you know exactly where is your positive margin area, or you go for radiation or observation. A lot of times the edges are not positive for invasive cancer, but positive for dysplasia. If I use NBI around 2 millimeters, yeah, it's very similar to what you do in TLM if you have a positive margin for TLM. Because the TLM, you only for glottic cancer, you only take 1 or 2 mm margin, and sometimes even positive. It doesn't mean it has a recurrence because the area is actually ablated. When you resect, when you ablated the area with a laser or your diathermy, so it may not be a true positive margin. It's only because the margin was ablated.
Any question?
But I'm talking about early cancers. I'm not, and also the positive margin is not cancer, but dysplasia. Cancer is different. If you have invasive cancer at the margin, you really treat that as an invasive. There is a cancer left behind.
Good. Any more questions for Raymond Chung? No. Any question from Zoom as well? No?
Okay, then we can. Well, thanks to everyone on Zoom for attending the course.
Today, healthcare professionals are treating patients in a variety of clinical settings and have a multitude of clinical